Thank you very much, Dr. Stanley, and it's a pleasure to be in Chennai. It is almost like a homecoming, the return of the prodigal person, prodigal offspring, that I come back from Bangalore because Chennai is my place, my uru. Okay. So, and I thank Dr. ESK for giving me this opportunity. I think it's evening. Most of you are refreshed with a cup of coffee, but I think I have been following the trend of the lectures since morning, and they have all been very, very heavy on medical, I think, the perspective and the paradigm. I'm a psychiatrist, as it has been said, and I'm going to talk about, I'm going to take a different paradigm and a different perspective while addressing the issue of dementia, because I think that as a chronic disease, neurodegenerative disease, as a medical model that we have very little to offer, probably we could take it up what we do in the discussion after the lecture and the question and answer. But what I am going to talk about is a public health approach, and how do we look at dementia in India, and what are the current problems in dementia in India, and how do we need to address it. Because I think that is where we are, when compared to all the other conditions which have been, whether it is stroke or I think osteoporosis, dementia, we are lagging a lot, because I think we have taken a longer time to come of age in India than the other countries, developed countries. Definitely medical technology all over the world is improving, and so also in India. I think with the India shining paradigm, there are more number of middle class people and people who can afford the health care in the private sector, if not in the government sector. And the government also has a reasonably well placed primary health care physician setup and the primary health care setup in India. And because of this, the mortality is decreasing and the birth rate also has come down. As a result of which, I think, and the awareness about the health, our elderly population is growing. In the 2001 census, it was said that the elderly population above the age of 60 was about 7.4. And in the 2011, rough census, they said that we have crossed 100 million, the people above the age of 60. So, and it is expected that we will grow to 177 million in 177 million in 2025. And so when we look at so many other illnesses which are all age-related, one important aspect of age-related illnesses is dementia, because where the most important risk factor is just the fact, especially I'm talking about Alzheimer's dementia, where age is the most important risk factor apart from other risk factors. So we know it's an acquired neurodegenerative condition with progressive diffuse cognitive deficits, especially memory usually starts with memory, and other aspects of aphasia, apraxia. And it has to interfere in the diagnosis, it has to interfere with the daily function, and it has to it should not be, I think enough has been talked about delirium this morning, and the previous speaker also talked about depression. Why this depression is very important is because depression is and depressive symptoms are some of the very common psychiatric morbidity or psychological issues in the elderly. If you see the last study which has been done in Mumbai, the depressive symptoms were as common as 50%. Symptoms I'm talking about, because there is a difference between symptoms and a syndrome. Depressive symptoms were as common as 50% in people above the age of 50, 55 and 60 in India. So, and that could mimic dementia, and that is very important. So this is the Lancet report by Ferry et al. This is part of the ADI work which has been done, and you can see that world over that the prevalence of dementia is increasing. But what is very important for us to understand is that somebody talked about it even in the osteoporosis, that people have in the developed countries, they have reached the peak and intervention measures have been taken, and so there is a dipping. I think here, when you look at the developing countries, the bracket of people who are old enough to develop dementia is sort of slowing down in the Western countries. On the other hand, in the developing countries, we are increasing by 100% and 200%. Okay, and there are a lot of issues which is not addressed in many of the developing countries. I'm not talking about Southeast, especially when you talk about developing countries, we are talking about the BRAC countries, the Eastern Crescent, and countries like the Indian subcontinent, and we are not talking about countries like Hong Kong or Singapore or Australia. So this is something which we need to understand. If you look at the problems in India, especially when it comes to dementia, the outline would be, these are the 4 aspects which needs to be looked at. One is the prevalence, then the assessment, the personal and the professional. I have not put it only as professionals because that is one huge story. The personal is also another huge important aspect. And the infrastructure. Let us start with the estimates of the prevalence. If you look at it, the first task force study on the elderly was done in 1981 by Professor Venkobra, late Professor Venkobra. In this 30 years or 32 years, there have not been many studies in 30 years. If it had been a developed country, there would have been more and more nationwide studies would have happened. But in our country, we have hardly 8 epidemiological studies across the country, and the maximum number of people who have been screened, the maximum is one by Mathuranath in Trivandrum, Kerala, and that included only 3,000 people. Of course, it was a 2-step sort of a screening, but the number of people who were screened were something like 2,689 people. So this is something which we need to remember, that not very large studies are conducted and they are spread across the country. And India is a very, very diverse country with very different socio-cultural, language, ethnic differences. And having only 8 epidemiological studies over 30 years is something which talks about that we need to do much more, and that is why we are not sure whether today dementia is an emergency. Is it a knock at the door for us to wake up, open the door and recognize it, or can we afford to ignore it for some more time, for the next 1 decade or the 2 decades to come? So, and that is one important aspect of it, that there are only 8 epidemiological studies. There have been small studies on intervention. For example, the Goa group is doing. I will show you the groups who are working on dementia in India on a persistent manner and a consistent manner. There may be many of the people, physicians, and who may be looking at people with dementia on a clinical basis, especially in the metros, but not in the rural areas. The awareness. So even if there are no epidemiological studies, what about the person himself or the family? Do they understand that there is something like dementia? Do they approach, what is the pathway to care? Is there a pathway to care very well sort of established? The pathway to care, especially in the case of dementia, almost seems to be non-existent, because often people think that it is part of aging. And so as a result of which, they do not even approach. And who is the most redundant person who's considered in a rural setup? The elderly, because they are no longer productive, and any sort of an investment in their health is not going to give the family any returns. So that is the easiest, in the shopping list. The health care of the elderly gets the lowest priority. So awareness being one, prioritization being the next one. So these are 2 factors where the pathway to care is very, very truncated and almost non-existent when it comes to dementia. And the health sector figures, we will look at it when we come to infrastructure and resources, and the health sector figures are not at all representative for a 1.2 billion population. We have hardly 100 memory clinics, we will look at it, and we do not have any other resources. What about training? So those are some of the issues we do not have. And when you look at the health coverage what sort of a policies and schemes and financial, subsistence which we have for our elderly in the country and for people, leave alone elderly. Do we have something for the people who have dementia? If my mother or father has dementia, can I avail certain services at a subsidized rate? I don't think so. Can I get donepezil? Can I get a diaper? An adult diaper costs me 50 rupees. So if I have to change 3 times a day, if my mother is incontinent, can I afford 150 rupees for incontinence alone if my mother is has severe stage of dementia? I don't think. Can I get it for 5 rupees? I don't think it is a very, very reality-based factor in India today. If you look at the groups, sorry if I have left out any other group, and I am willing to stand corrected here. We have been working for the past, I think initially we ran for about 10 years, then we had a gap of about 3 to 4 years, and then we have restarted in the last 12 years. We are consistently working in the area of elderly, not only dementia, but also late onset depression and late onset psychosis, and ours is a multidisciplinary team. I think that is a luxury. That's a luxury in India, because how many places will you have a neuropsychologist, a neurologist sitting with you, and a speech therapist, and also a physiotherapist sitting and helping, and a social worker who runs a group. It's a luxury to have a multidisciplinary team, and that is what we are having, and I'm eternally thankful to that. And Krish's team, which is working very well in India, in Chennai, and also Satyanathan, who has a lot of interest and who is currently the vice chairman of the ARTSI, which is the Alzheimer's and Related Dementia Society of India, who is a vice chairman of that NGO. Jacob in Vellore, again, has been working very consistently as a part of the 1066 program. Shaji, again, in Kerala. Madhuranath in Trivandrum, he is the person who has done a large epidemiological study. Swarna Alladi, Manjari Tripathi, Dr. Tiwari, Das, and the Pune group, which has done work along with the UK group. So it's only these 10 groups who are being consistently working in the area of dementia. All the others are working at their own individual level, and that is not a very good thing. So what do we know about the numbers currently? If you look at the numbers here, you would find that there is a significant, though, is there a pointer here? Okay. No, sorry. Okay. Okay. If you look at it, you would find that the mean is very different. These are all the 4. This is a very large Indo-US study, Balaberg, and this is the Dr. Das' study. This is Dr. Vijay Chandra and Mary Ganguly study. I think this is Krish and the others, Kerala, Madhuranath, and also Shaji's study put together. You would find that when you look at the prevalence of dementia numbers in India, they almost vary between 0.9. In some cases, it is 0.3 to 12. So why is there? And some people said this is because of Kerala is such a developed state that we are almost like a developed nation. So we are having a higher prevalence. But that was not so when it came to Thrissur study. So this confusion had to be put to. And this is the international Eurodem prevalence. So this had to be put to rest. And what the 1066 group did was to understand why there is so much of a variation in the prevalence of dementia in India. If you look at it, that the tool the classificatory system which you use to diagnose. So if I say that if somebody, anybody who's above the, 5 feet 6 inches can all be one group. If you define something and you sort of start dividing people based on your division, your description, the diagnosis also change. And that was very evident in DSM-4 and DSM-5. Because in DSM-4, we have the disturbance in executive function and significant impairment, especially in social or occupational functioning, decline from a previous level. In the rural setup in India, Once somebody is about 50 years old, you do not expect them to take a lot of responsibility and be very, very active as a sign of respect. So when there is dementia, people do not understand that there is a significant reduction in the social or occupational functioning. You never expect any Indian elderly in a rural setup to go to drive a car, to go alone in a bus, or go and do a financial transaction. Everybody may come and provide information, but in a rural setup, this is not so. And the disturbance in the executive function, we will talk about it when we come to the neuropsychological testing, that this was a concept. I do not know how many of you are neuropsychologists here. One of the neuropsychological tests of executive function, which we very, very commonly do, is Tower of Hanoi. You know, you have seen children have rings, and then there are two other empty ones. You have to transfer in that many number of steps without, you have to think about it in your mind and transfer all the rings in the same order, decreasing order. That's Tower of Hanoi. If you give it to, and usually the number of rings can vary. It can be 3, it can be 4, it can be 5. It is usually 7. But if you give that to an Indian elderly, the first thing he will say is, no, I don't want to do it. So how do you make somebody? So do you presume that as a person not being able to do the executive function planning? Or is it just refusal because there is no familiarity? And he has never done this in his life. So this is something which we need to understand. So the problem of use of DSM-4 was sort of recognized by the 1066 group, and then you can see that it was actually in India, the prevalence was considered something like 1% earlier. This is the 1066 DSM. You can see that when you re-diagnose them using different criteria, removing the executive function, and then sort of thinking about how you have to define occupational and social decline, then the percentage actually increased to, instead of 1, it became 8%. So the way we describe something also decides whether there is a problem in a society or not in a society, and whether we have to pay attention as a health sector or not in a health sector. That is very, very important, and that's what this slide sort of indicates. So now we have come to some sort of a consensus that currently we have 3.7 million people who are suffering from various types of dementia, predominantly Alzheimer's, and they are going to double every 20 years, and it's going to go up and up. And that's the burden. I think, again, it's in a sort of a histogram. We come to the assessment, and that's a very big bugbear in dementia, because we have various tools, and in all over India, people use different types of screeners and different types of detailed assessment. And none of them seem to cut across because of the types of languages, dialects, and the literacy rate across the country. And there is a difference between men and women also. So the Balaburg study said that average Indian rural person is illiterate, so we are changing the MMSE. So instead of 30, we have 31. We have changed the initial questions in orientation from who is the Prime Minister of Britain, that and all is changed, and we have made it much more Indian friendly, and that was used. And if you look at it, even that, in many of our patients, when you ask them, what day is it today? Or what month is it this month? They say, I'm never aware of, I never knew the month or the day because I always work in the fields. So do you say that they are not oriented? But when you ask them, and many a times the assessment happens in a hospital. So when you ask them, what is this, or what block is your village, they will talk about their village block, but not about the hospital, because they do not know that this is a hospital. We have come to a bigger city. They will know that they have come by bus, and I am a doctor, or the person who is examining is a doctor, that it is in the first floor. But they may not be able to say, yes, I have come to Bangalore city and I am in NIMHANS. So that sort of so often it is very difficult for us. And in a regular assessment, I do not know how many of you do, when you do a very detailed assessment, you cannot change the questions the way you want and still say, yes, I used HMSC. You have to use it the way it has to be used. You can repeat it, you can say it once, and if the person doesn't understand, you can repeat it once more, but you cannot give cues. Did you come by bus? Did you climb anything? You cannot say any of those things, which people may be doing, and those are not valid tests. So that is very important. And many people use the AD8 screening, 1 minute question of how many vegetables can you say? How many animals can you say? That's also a screener, Minicog and MOCA, which is very, very popular, and it's from Canada. So there is no uniformity in the assessment, in the screener of the, even when we go into the community or in the hospital-based work. And the more detailed tools, again, they have the same thing. Each one of them, whenever there is a study, people come up with their own tools, and now we have the Copeland's GM, General Mental Status Examination, which was originally by John Copeland, and now it has been further developed in Liverpool. So what seems to common is the clinical dementia rating scale, which assesses the severity of dementia. All the other things are not at all common. The neuropsychiatric inventory, which is the reason why they come to a psychiatrist, because 85 to 90% of the people with dementia have some behavioral and psychological problems. They come, and if you have to assess them in a very methodical manner, you have, again, different types of them, and many of them are not standardized. We do not have the Indian norms for the normal population, elderly, and we do not have the validation. They might have been changed into, they have been translated into vernacular and back translated, but whether people have looked at all the psychometric properties of a particular tool is something very, very doubtful, because it is to do in each of the language is extremely expensive, which would mean money. So to add to that, we have also, because it was only for the HMSCs for the illiterate rural population, also an urban illiterate population, we have developed the one neuropsychological battery which is used all over India for people up to the age of 50 with norms, is from NIMHANS, which is Rao et al.'s battery, neuropsychological battery. I'm sure people who are here, neuropsychologists, would know about it. This is for all the people, whether it is stroke or post-surgery, pre-surgery, they use it, and it has been sort of well standardized across the country. But we do not have norms above the age of 50. To set it right, we have somebody who's working on this area, and we have a population which has been, we have neuropsychological tests developed for population between the ages of 50 to 80. 80 is our cutoff because we find it very difficult to find people beyond the age, both for illiterate population and also a part of the literate population. And we have also used it as a sort of whether it is sensitive enough to detect mild dementia and MCIs. And we find that yes, we need a lot more work to be done, but the norms are being set up, and that is one among the Ravikesh Tripathi is doing it as a doctoral thesis. And Dr. Swarna Alladi always talks about it. She says that how she is able to, if you ask somebody to write or construction, they are not able to do. But if you ask them to draw a rangoli, which is the floral design, many of them can do it. And we need to have culturally adapted rangoli things to be used. I'm sure somebody is laughing from the audience, but if you look at the proof which she has got, they're saying that a person who has got mild dementia, moderate dementia, what happens to the same person's rangoli drawing when they become severe dementia is something phenomenal. But she has not standardized it, but she can show beautiful pictures of what happens to a person when a person who's used to drawing rangoli every day in front of the house. Personnel, okay, so we do not know the numbers. Even if we identify them, we do not know how to assess them in a methodical manner. Do we have the people to treat them? So for 1.2 billion, we have about 2,000 neurologists, less than 4,000 psychiatrists. When it comes to psychologists and social workers who form the crux of care, psychosocial care of dementia, we are very, very poor. Less than 2,000 social workers. And the concept of a geriatric nurse is just starting. We are having people from other countries who are coming and saying, can we train your nurses and can they become exclusive geriatric nurses? There may be some hospitals where they are posted and they pick up the skills as they go along, but do they get trained specifically? Do they have the knowledge? I do not know. Okay, so training of the health aides, I do not know how many of you know, if you are in the government of India, Department of Health and Family Welfare is the one which is responsible for the health sector, and it has got the National Rural Health Mission program. And under the government of India National Health Program, you have the multiple health workers, multi-purpose health workers. You also have like you have for the children, Anganwadi workers. Now we have the ASHA workers who are the health activists. So there are initiations where people say that we need to train them apart from the other national program. We need to train these people, sensitize them to what is dementia. Do not consider that it is part and parcel of aging, but to actually go back and sort of check and provide the primary health care physician with some skills to confirm. If an ASHA worker says, yes, I have found somebody in this street and in this house with memory problems, and the lady also seems to be wetting her dress, can I bring her over? Will you be able to actually confirm whether she has dementia? Then the primary care physician should be able to confirm it, and if necessary, refer to the district level hospital or to a higher hospital. So both at the ASHA level worker and also the primary care physician need to be provided some amount of training before we can think that all of them can go either come to Chennai or go to Vellore or go to NIMHANS or to Calcutta. So that is not a possibility, because unless we have a pathway to care, the whole the care system and the pathway is going to be actually break down under pressure. And in the curriculum, if all of you look back at your own medical curriculum, what was the importance given to dementia as a neurodegenerative disease? What is the importance which is given in the nursing curriculum as palliative care or as tertiary care? This is the infrastructure we have if my mother becomes, as I said, has dementia. There are 100 memory clinics mainly in the cities to diagnose and assess the people. There are about 10 daycare centers exclusively only in big metros, not even class B metros, it is class A metros, 2 of them in Delhi, one of them in Bangalore, I do not know whether it is there one of them in Trivandrum. So it is mainly in class A metros. Residential care, I think they are present in about 6 of them. Domiciliary services where the person goes home, either the nurse or the health aide provides care at home, that is also less. And dementia helplines are about 10, and we do not know how many support groups are there, because support group is one among the most important aspect of dementia psychosocial care, because we do not have anything else to offer except the support by each other that they learn from their own people who are in the same path and who are in the same boat. Economic cost. This is one important lesson, because we thought about 10 years back, it doesn't cost anything in India to look after a person with dementia. Because when 1066, I'm sure Krish is here, they did an assessment of how much does it cost to look after a person with dementia. And the figure which they came out was $0.6 per month, which is somewhere between 30 rupees to 175 rupees. We went back the last year we said we will rework it, and we did and reworked the whole thing. And now we have come up with a figure of, I'm having a project which is looking at the cost of dementia compared to cost of other mental illnesses, major mental illnesses. Right now, our cost calculation is 147 billion. If for 3.7 million people with dementia, we are not including other illnesses at all, it's only dementia. Of course, the difference between other countries, developed countries, and India is that there it's the formal care, which is about 3/4, here the informal care. So people do not think about lost wages, informal care, lot of time, the pain factor of it, and people do not calculate it, the purchase purchase power parity. When we did all those things, it has come up to 147 billion. So I think it is high time that we woke up and then said, yes, we need to do something about it. So this is brought out in this Dementia India report, which we all wrote in 2010. And I think always sometimes, things can happen better in a government when somebody is ill. If somebody in their family, I'm not wishing anything, but what I'm saying is, it is the presence of, one of the former vice president's wife having Alzheimer, one of our earlier ministers, that we have more and more questions in the parliament about dementia, and there is some interest in the government about people with dementia, that we need to do something about it. And we have brought out the report that there is a need to look at this condition very, very seriously. Just as we need to look at something like diabetes, we need to look at dementia. I'm sorry about that it is very, very blurred. You can see that the problems which we are facing are, one is stigma, definitely, because often people do not understand the difference between dementia and a psychiatric illness, and they use the same word, something like, pagal. So it can be, they think that the person is mentally ill rather than actually the person is having difficulty in cognitive symptoms, lack of awareness, we talked about, low health setup, expenditure, lack of policy, and I think what I have written, what is written there is lack of training and support, lack of funds for research. Okay, the recommendations we have made is that it should become a national priority. Especially it should be seen in the national policy for the older people, which is getting revised now, and it needs to be seen in the national policy for the older people, and there should be an increase in the funding for research in dementia. There needs to be a lot of IEC activities, whether it is through using various media, and that has to happen. That's why we have taken up very, very many things on Alzheimer's Day, which was yesterday. Increased identification, whether it is the screening, and then the second level of identification and providing scarce skills, support, and support packages need to be there, because identification is only the first step, and if we do not provide them either with support or with care, there's no point in identifying them. And we are also trying to set up in the community some comprehensive care integrated model in the community, which is near NIMHANS, and I hope there are other people who are setting it up, and that becomes a model. For example, Dr. Amit Dias, who's from the community medicine in Goa, has shown that a model of 3 visits to the house in a person who has moderate dementia can be of significant help to decrease the carer burden. So he had a randomized control, and he has been able to establish this. And I think I'm open to questions. I might have been very negative, but I thought that we should we should sort of take stock of our holdings before we proceed forward, and I think I'm open to questions and criticism, and I thank the geriatric group from NIMHANS for all the support and the comradeship which I have. Thank you, sir.
Thank you, Dr.